Rheumatoid arthritis, advances explained, step by step. 1. Big picture. In recent years, our understanding and treatment of rheumatoid arthritis have advanced a lot. We now know more about the exact immune cells driving the disease. We have better imaging tools, new targeted medicines, and we're starting to personalize treatment based on patient risk and biology. 2. Pathogenesis. What's new? Traditionally, RA was seen as just joint inflammation. Now, research shows the joint lining has different cell types. Some patients have immune cell-driven disease, while others have fibroblast-driven inflammation. This explains why not everyone responds to the same drug. Example, if fibroblast activity is high, drugs targeting immune cells may not work well, and other treatment strategies may be needed. 3. Role of innate immunity and microbiome neutrophils. Through a process called netosis, and bacteria from the gums and gut can trigger autoantibody production. Why this matters? Good dental care and smoking cessation aren't just lifestyle tips. They can actually help reduce RA activity. Example, a patient with severe gum disease and RA often sees improvement in joint symptoms once gum health is treated. 4. Biomarkers and precision medicine. We're moving from trial and error to predicting which drug will work for which patient. Certain blood protein patterns and early treatment responses can now signal whether a patient will do better on a TNF inhibitor or an IL-6 blocker. Example, if a patient's blood test shows strong IL-6 pathway activity, starting an IL-6 drug may give faster remission compared to cycling TNF drugs. 5. Imaging and artificial intelligence. Ultrasound and MRI now detect hidden inflammation that physical exam can miss. Power Doppler ultrasound can predict who is at risk of flare even when the joints look quiet. AI tools are being developed to read these scans more accurately. Example, a patient in apparent remission but with hidden Doppler signals may flare if the drug is tapered, so the doctor may decide to continue treatment. 6. Therapeutics. New and evolving options. JAK inhibitors are powerful oral drugs working quickly and effectively, but they come with safety cautions. In older patients with heart disease or cancer risk, they are used carefully. Anti-GM-CSF drugs and bispecific antibodies are new types of biologics showing promising results. Cell-based therapies like CAR-T are being studied for severe, treatment-resistant RA. Example, a young patient with aggressive RA and no heart risk may do very well on a JAK inhibitor, while an older patient with a history of heart attack may be better managed with abatacept or rituximab. 7. Difficult to treat RA. Some patients don't respond despite trying multiple drugs. These are called difficult to treat RA cases. Before labeling them as such, doctors check for medication adherence, other health conditions, and whether pain is truly inflammatory. Example, a patient with persistent joint pain but no active inflammation on ultrasound may actually have fibromyalgia, not uncontrolled RA, so changing biologics won't help. RA with lung involvement. RA can cause interstitial lung disease, which is serious. In these cases, certain drugs like rituximab or abatacept may be safer choices than TNF inhibitors. Example, a patient with progressive lung scarring in RA may be started on rituximab to control both joints and lung disease. 9. Tapering therapy. In patients with long-term remission, medication can sometimes be reduced slowly, but full stopping usually leads to relapse. Example, a patient in remission for a year may reduce methotrexate dose gradually, but stopping everything suddenly increases the chance of flare. 10. Cost and access. Biosimilars, cheaper versions of biologics, called biosimilars, now make advanced treatments accessible to more patients worldwide. This allows earlier escalation and better long-term outcomes. 11. Future directions. Personalized treatment guided by blood and tissue biomarkers. Drugs targeting joint lining fibroblasts. Bispecific antibodies and nanobodies for better targeting. Cellular therapies like CAR-T for severe resistant cases. 12. Clinical vignettes. Older patient with heart disease. Avoid JAK inhibitors, choose safer biologics. RA with lung fibrosis. Rituximab or abatacept preferred. Difficult to treat RA, confirm true inflammation before switching drugs again. In summary, advances in RA are shifting care from a one-size-fits-all approach to personalized medicine, where treatment depends on biology, comorbidities, and patient preferences.